invasive biomarker testing for the diagnosis and the management of autoimmune hepatitis. Broadly, to define, autoimmune hepatitis is characterized by interface hepatitis, which is the histological hallmark of the disease, and plasma cell infiltration, lobular hepatitis, lymphocytic infiltration of the liver, and peripolosis and hepatic rosette formation. And biochemically, it is characterized by high level of AST, ALT, serum immunoglobulin G levels, autoantibodies, and the presentation can vary from acute hepatitis to ACLF and cirrhosis. This is the broad diagnostic algorithm for the evaluation of the suspected autoimmune hepatitis. In a case of suspected autoimmune hepatitis in adults, anti-nuclear antibodies and smooth muscle antibodies, ANA, SMA, LKM in pediatrics, plus a liver biopsy is a mandate to diagnose autoimmune hepatitis, which is characterized by interface hepatitis plus minus plasma cell infiltration. To rule out overlap, there is bile duct injury or loss. To rule out superimposed NASH, which is characterized by fat in the liver biopsy. If the first line of the antibodies is negative, then the next line is basically anti-soluble liver antigen P-ANCA, TTG, AMA, and if it is SLA is positive, we label it as autoimmune hepatitis. Everything is negative, and biopsy is basically suggestive for autoimmune hepatitis, can be labeled as antibody negative autoimmune hepatitis. Then P-ANCA can be positive in autoimmune hepatitis or overlap with primary sclerosing cholangitis, TTG with celiac disease, and with anti-mitochondrial antibody with PBC or overlap. These are the broadly the autoantibodies which are used in the diagnosis of autoimmune hepatitis. First is basically anti-nuclear antibody, which can be seen in up to 80% of the patients, and it is against the chromatin ribonucleoprotein antigen and seen in type 1 autoimmune hepatitis. SMA is basically against the filamentous actin, vimentin, and desmin, and seen in approximately 63% of the patients. LKM is against the cytochrome P452D6. Anti-soluble liver antibody is basically against phosphocyarin transferase RNA, selenocysteine transferase RNA synthase, and usually is present in type 1 autoimmune hepatitis, predicts severe AIH, and predicts relapse after the treatment and associated with poor outcome. P-ANCA is usually atypical against beta-tubulin isotype 5 and nuclear lamina protein, and can be seen in autoimmune hepatitis, primary sclerosing cholangitis, and autoimmune sclerosing cholangitis. Actin against the filamentous F actin, anti-actinin, LKM3, anti-liver cytosol, and liver mitochondria, and anti-mitochondrial antibodies are the other antibodies which are seen and used for the diagnosis of the autoimmune hepatitis. So why the biopsy is needed in autoimmune hepatitis? The diagnosis of the of autoimmune hepatitis needs liver biopsy and has compatible histological findings. Cirrhosis at the time of diagnosis can be seen in up to 1/4 to 1/3 of the adults as presentation and approximately 40% of the children. Histological examination at presentation will help in excluding the alternative or the concurrent diagnosis, grading the severity of the inflammatory activity, and staging the fibrosis. Concomitant NASH can be associated with autoimmune hepatitis in 17 to 30% of the population, and presence of both the disease increases the risk of liver-related mortality and adverse outcome. And biopsy is also needed for the drug withdrawal. It is a preferred therapy, not a mandate, as per the ASLD guidelines right now. Sustained normal AST, ALT, IgG level for at least 2 years are the requisite before attempting the treatment withdrawal. Restoration of the liver tissue to the normal in histology reduces the subsequent relapse to up to 18%. Liver biopsy prior to the drug withdrawal is a preferred strategy, but it's not a mandatory as per the guidelines. Relapse during the or after the immunosuppression withdrawal is common in AIH, can be seen up to 80% in some studies. Presence of active autoimmune hepatitis on liver biopsy despite the normal transaminases predicts the relapse. Relapse can be seen in up to 50 to 90% of the adult and up to 60 to 80% of the children after the withdrawal of the drug. Biochemical normality for more than equal to 2 years, reduces the relapse frequency to 46%. 50% of the relapse are usually seen within the first month after the drug withdrawal, and the frequency of the relapse decreases after the first year to 3% per year over the next 3 years. The goal of the therapy is basically to maintain ALT level of less than 50% of upper limit of normal and IgG level of less than 1200 milligram per deciliter sustained for 2 years, and only if the goal is maintained, only the 46% of the patient experience relapse after the cessation of therapy. This figure basically shows the patient who had AST sustained suppression of AST level, gamma globulin, and IgG concentration in serum at the time of the withdrawal of the drug, maintain sustained remission as compared to the patient who had higher AST, gamma globulin, or IgG level at the time of relapse. AST 32 versus 25. And gamma globulin of 1.4 versus 1.2, and serum IgG of 14 versus 10. Basically, higher AST level at the time of it, or the flares in between, higher gamma globulin or higher serum IgG level at the time of withdrawal of the drug predicts the relapse. This basically shows how the histological disease activity varies as per the ALT or the IgG level. This is the patient with no cirrhosis. In patient without cirrhosis, if the patient is having ALT and IgG normal, approximately 2/3 of the population had histological activity index of 1 to 3. With only IgG and ALT elevated, histological activity with high IgG or high with either high ALT or IgG level, approximately two-third of the patients had histological activity index greater than 6, and with the elevation in both ALT and IgG, approximately 80% of the patient had histological activity index greater than 6. Recent studies have showed that liver biopsy is preferred but not mandatory. However, in patients with cirrhosis at baseline and autoimmune hepatitis, biochemical remotion was shown to be inadequate reflection of the histological remission. This basically paper published in JHEP reports in 21 basically compared autoimmune hepatitis without cirrhosis with normal ALT, autoimmune hepatitis without cirrhosis with normal ALT and IgG. The histological activity index correlated with the biochemical remission. With normal ALT and normal ALT and IgG, the histological activity index was less than 85, 88, and 95%, less than 4 in these group. However, in patient with cirrhosis with normal ALT and the histological activity index was 26%, in less than 4, it was between 4 to 5 in 38, and was histological activity was more than 36% with normal ALT level, sustained normal ALT elevation. The histological activity index was more than equal to 6. In patient with autoimmune hepatitis with cirrhosis with normal ALT and normal IgG, the histological activity index more than 6 was seen in 29%, and more in the range of 4 to 5 was seen in 41% of the patients. So the biochemical parameters correlated with poorly with the histological activity index in patient with autoimmune cirrhosis. However, without cirrhosis, the biochemical remission can be taken as a surrogate for the reduction in the histological activity index. To understand the biomarkers, and we need to understand the pathophysiology of the autoimmune hepatitis. It is basically predominantly a T cell mediated disease, and there's a dysregulation of the T cell and the cytokines, and this basically shows the potential biomarkers as per the activation. It is basically the activation of the CD4 cell, which basically stimulates the helper T cell, leading to the stimulation of the Th17 cell, Th1 cells via the interleukin 12, 18, 4, and 6, 21, 21, 23, and TGF beta, which basically stimulates the Th17 cells, which in turn stimulates the interferon cascade, leading to the inflammation that is via the interferon gamma, IL-22, 23, and IL-17. These are the Tregs or FOXP3 cells which are down-regulated, and the CD4 cell usually has a tendency to go towards the Treg cells and basically suppress the inflammation while suppressing the Th17 cells. This basically shows the natural history of the autoimmune hepatitis and the candidate biomarkers. There's a preclinical phase and followed by a clinical presentation in the induction phase. And in this preclinical phase, the genetic biomarkers can help in guiding the course of the disease. However, they are usually not feasible to screen the population. In the patient presenting with the clinically, Treg cell serum, IL-17 serum, we'll be discussing these in detail. Serum ADA level, ferritin, vitamin D, TGF beta, B cell activating factor, DNA is 1, anti-sialoglycoprotein antibody, then the ratio between the regulatory T cells and the ROR gamma T ratio, and macrophage migratory inhibitor factors and the soluble CD4 ratio will help in guiding the course of the disease during this phase. The course is broadly divided into the preclinical phase, clinical presentation, and the induction therapy. Then there's a phase of remission or drug withdrawal, followed by a stage of relapse or retreatment, and then there's a maintained immunosuppression. In the preclinical phase, HLA and non-HLA based polymorphism such as DRB1, 0301, SH2B3, CAR10 can be used. However, they are not routinely recommended for screening for the general population. They can be used to stratify the risk in the patient with who are having underlying autoimmune feature. So it is coming on to the clinical phase. It is the T cell mediated immune response. In the frequency of the T cells secreting IL-17, TNF alpha are significantly increased, and the serum level of IL-17 correlates with the liver injury, and the level of the circulating Th1, Th17 cells are significantly decreased after the immunosuppressive therapy. This basically showed how the CD3, CD4 and interferon cells are increasing in patient with autoimmune hepatitis, and in the remission they are comparable to the control. Similarly, IL-17 cells are also increased in patient with active autoimmune hepatitis. The interleukin 17 levels are increased, and correspondingly there's an increase in the interferon gamma and CD3, CD4 plus and IL-22 cells, which are increased in the patient who are having active autoimmune hepatitis. This was a study which was done after in a mice model with experimental autoimmune hepatitis induction. This showed there is an increase in interferon which basically peaks at day 28. Similarly, there is an increase in IL-17 which basically after the induction of the mouse with the experimental autoimmune hepatitis, there is an increase in IL-17 which usually peaks at day 28. Similarly, IL-22 also increases, and there is a gradual decline in the regulatory T cells. Similarly, there is an increase in the interferon, IL-17 and IL-22 level, and there's initial increase in the liver IL-22 level, which basically gradually declines after the day 28, up to day 28. Serum adenosine deaminase has been also studied as a predictor of the inflammatory activity. The level of the serum aminodeaminase level vary with the mild, moderate, and the severe disease, and the mean level was 15. Moderate in the moderate it was 23, and in severe it was 30.9, and the cutoff of 25.25 with the sensitivity of 84 and sensitivity of 88.9% and specificity of 89% has been shown to predict severe disease in autoimmune hepatitis. Vitamin D, the level of vitamin D also has been shown to correlate with the severity of the autoimmune hepatitis. Patients with a lower serum vitamin D level at the baseline are more likely to have treatment non-response and higher liver-related mortality. They had higher risk of developing cirrhosis with a hazard ratio of 3.4 and a higher risk of liver-related mortality or requirement for liver transplant with a hazard ratio of 5.2. How does a deficient production of vitamin D leads to the proliferation of the immune cells? It basically it causes the failure to modulate the DNA polymerase and the protein kinase activity. There is an impaired activation of the regulatory T cells. There is a limited production of CTLA4 and IL-10, and there is an increased expression of TLR, and there is an impaired synthesis and rejuvenation of the glutathione, causing oxidative stress. Coming on to the next marker, that is serum TGF level in autoimmune hepatitis. It is usually immunosuppressive cytokines. However, it has been shown to be elevated in autoimmune hepatitis. The median level of TGF beta is usually 109 nanogram per ml in active autoimmune hepatitis, and after the biochemical remission, the normal range is around 30. It has been shown to correlate with the histological disease even in the settings of normal AST and ALT, and can be used as a proxy for predicting the histological activity and remission. In active autoimmune hepatitis, and there's an elevation of the TGF beta, and with the immunosuppressive therapy there was a reduction of the TGF beta which was seen. It is a pro-fibrogenic cytokine, and basically correlates in the biopsy with the fibrosis. Coming on to the other marker, that is hyperferritinemia and hypergammaglobulinemia. Hyperferritinemia, ferritin elevated level more than 2.09 time upper limit of the normal, and lower IgG level have been correlated with the complete biochemical remission. There is a decrease in the hepcidin level, and there is an increase in the hepatocyte growth factor, which basically leads to increased ferritin. Ferritin increased level is correlated with the biochemical response, and patient with a ferritin level more than 2.0 time upper limit of the normal have a complete biochemical remission as compared to the patient with a lower ferritin level. And the ferritin level is usually reversible, and it reverses earlier than ALT or in the IgG level. Coming on to the other markers of the clinical activity, that is B cell activating factor and interferon inducible protein 10, which is higher in patient with autoimmune hepatitis, and the mean level of B cell activating factor is usually around 1795 picogram per ml, and the interferon inducible protein 10 is 604, and it is higher than seen in other in PBC or chronic hepatitis B. Similarly, in patients who are having more grade of fibrosis, usually have a higher IP10 and BAF level. Coming on to the regulatory T cells and their impairment in the autoimmune hepatitis. In healthy, there is basically autoreactive T cells. However, they are counteracted by the CD39 positive Treg cells, and they basically produces adenosine, which is kind of immunosuppressive. However, this function is dysregulated, and there is dysregulated secretion of the adenosine, and the cells are also present in the lower frequency, and this basically promotes the autoreactive T cells, which in turn leads to increased secretion of the IL-17 and interferon gamma, and causing the liver damage. This basically showed that as compared to the healthy subjects, there's a decreased level of the T regulatory cells in the autoimmune hepatitis. However, there was a study published in Journal of Hepatology in 2012, which basically shows that Treg cells are comparable in a patient with active disease in remission and healthy control. There was no significant changes in which are seen in between the CD25 or CD127 positive cells, and the demethylation of the FOXP3 cells is also comparable in the patient with autoimmune hepatitis on active disease or in remission. So coming on to the next marker, which is the DNase activity, which is low in patients with autoimmune hepatitis, PBC, primary sclerosing cholangitis, as compared to the healthy disease or patient with Nephelt or viral hepatitis. This basically shows that the autoimmune hepatitis is promoting the apoptotic death, and this DNase level helps in clearing the apoptotic cells. However, it is impaired in patient with autoimmune hepatitis. And elevated level of DNase level can be used as a surrogate for predicting a complete response. In patient with complete response, the DNase level is higher as compared to the patient who received partial response or there was no response. Similarly, after the treatment, there is an increase in the level of DNase 1, which was noted in patient with autoimmune hepatitis. So coming on to the markers for the drug withdrawal, they are basically to stratify the patient before the withdrawal of the immunosuppressive therapy, monitoring the clinical decision making, frequency of monitoring after the immunosuppressive therapy withdrawal, considering the risk and the benefit discussion with the patient should be more sensitive than the currently available serological test, and detect the early signs of immune activation. The first marker is basically the ratio between the FOXP3 cells over ROR gamma T cells, which basically correlates with the autoimmune with the histopathology. The ratio is less than 1 in severe disease. There is a proliferation of the this Th17 cells over FOXP3 cells, and with the this ratio less than 1 is usually correlated with the increase in the interface activity or the increase in the histological activity index. In the subacute and the chronic, the ratio is more than 1, and in chronic it reaches up to 224. Similarly, in patient with chronic DILI versus autoimmune hepatitis, in autoimmune hepatitis the ratio is usually less than 1. In DILI it is more than usually 1. This was a study which was published from PGI Chandigarh, which basically correlated the ratio with the histological activity index and fibrosis scoring, and the patient with the FRGT ratio less than 1, basically it shows it correlated with the portal inflammation and interface hepatitis and the histological activity index. The other marker is anti-PD-1 antibody, which basically is an inhibitory T cell receptor, which helps in the regulating the T cell activation. In patient with autoimmune hepatitis as compared to the other etiology, DILI, acute viral hepatitis, primary sclerosing cholangitis, there's an increased level of anti-serum PD-1 level, which is noted. It can be noted in up to 63% of the patients with type 1 autoimmune hepatitis, 8 with DILI and AVH, and primary sclerosing cholangitis 13 and 18%. And in type 1 autoimmune hepatitis patient, it basically correlated with the serum bilirubin level and ALT level. However, not with the serum IgG level. And the positivity for serum anti-PD-1 antibody was associated with the later normalization of serum ALT level. And after the withdrawal of the immunosuppression, 66% of the patient who relapse in anti-PD-1 positivity, while 31% in who were not positive. Similarly, anti-SLA antibody has been shown to a marker of hepatic death, and relapse is also higher with the positivity at the time of baseline or the time of withdrawal. The other markers are basically anti-sialoglycoprotein receptor antibody, which is usually high in active disease and usually decreases in the post-immunosuppressive therapy, and usually it increases prior to the elevation of the liver enzymes and can help in predicting the potential early relapse. Similarly, macrophage migratory inhibitory factor is basically a target for the Th1 mediated autoimmune disease, and it is elevated in patient with autoimmune hepatitis despite the corticosteroid therapy, and minus 173 single nucleotide polymorphism in macrophage migratory inhibitory factor promotes correlation with the promoter correlates with the resistance with the steroid therapy in autoimmune hepatitis and other disorders. This basically shows the macrophage migratory inhibitor factor is higher in autoimmune hepatitis and as compared to the PBC, and this is basically a immunosuppressive and a marker CD74, and it is higher in PBC. They were compared between the control versus the autoimmune hepatitis and PBC, and CD74 level were lower in autoimmune hepatitis as compared to the primary biliary cholangitis. Circulating microRNA can also help in patients with type 1 autoimmune hepatitis. The microRNA which are studied and have been correlated with the disease activity are microRNA 21 and 122, and basically they have been shown to correlate with the high ALT IgG level and histological activity index. And this basically shows the macrophage activator soluble marker 163, which has been shown to correlate with the disease activity and the treatment response in patients with autoimmune hepatitis. This basically showed that the higher level of CD163 correlated with the higher ALT and IgG levels. Transient elastography can also be helpful in monitoring the disease course in the autoimmune hepatitis, and basically the complete biochemical response was compared to the patient who had elevated and aminotransferase level and IgG, and remission was basically noted in patient who had the decline of fibrosis by 7.5% per year versus no remission who had increase in the stiffness by plus 1.7% per year. These basically summarizes the various biomarkers and the studies which have been done in the autoimmune hepatitis. From the initial presentation, the biomarkers that can be used are TGF beta, TNF alpha, then B cell activating factors, serum ferritin level, vitamin D level, serum amino D-amines level. This basically they show whether they increase risk or they are the protective. Remission, these are the biomarkers which can be studied: regulatory T cells, DNase level, then FOXP3 T regulatory cells. And during drug withdrawal, anti-PD-1 antibodies, the ratio between the FOXP3 cell and ROR gamma T TF ratio, then ROR gamma T TF level, and IL-22 mRNA. And in relapse, macrophage migratory inhibitive factors and the presence of the anti-sialoglycoprotein receptor antibodies and anti-soluble liver antigen can help in predicting the relapse. So the non-invasive peripheral biomarkers, they are basically the surrogate for the histological activity versus the quiescence, and they can be at the level of gene expression, protein or metabolites, and immune cell types, and they should correlate with the histological activities, and the should vary with the disease activities. And this is the roadmap for the discovery and validation for the candidate biomarkers. It should be biologically plausible, non-invasive from the peripheral blood, should correlate with the clinical markers and the disease state, and should be acceptable inter-assay variability. The testing site should be single and should be validated in multi-centers, and should be sensitive and specific, and should be a metabolite of hepatic T cell activity and measured in the peripheral blood with autoimmune hepatitis, and should predict relapse and disease remission in patients with autoimmune hepatitis. So there is a need for biomarkers in autoimmune hepatitis in improving the personalized management of autoimmune hepatitis, in early identification of the disease, early response to the therapy, predicting the relapse and withdrawal of the immunosuppressive therapy, and it should vary with the different stages of the autoimmune hepatitis, and should vary with the key clinical stage, that is activity, remission and relapse. Thank you.